name is Nadia Shehri. I'm pharmacist with the Master of Public Health, Epidemiology and Biostatistics. Today, I will be discussing an essential topic in clinical research, the source of bias in randomized clinical trial, or RCT. As a source of bias in randomized control trial, we know are considered the gold standard for evaluating healthcare intervention, but they are not immune to biases, as we know. So that can impact the validity of the results throughout I think throughout this presentation, we will explore the different type of bias that can occur in the clinical trial. So starting with, here is like a roadmap for our discussion today. First, we will introduce the concept of bias in clinical trial and explain why it's critical to understand and manage. We will examine the 7 evidence-based domain for assessing bias and discuss practical strategy for how to mediate the common type of the bias. And after that, we will review some key critical appraisal to use the identify assess bias. We will also talk about additional bias types specific to the complex trial design and the ethical implication of the bias in clinical trial. And then finally, we will consider the impact of the bias on research outcome and explore future direction for improving bias management. So in the introduction of the bias in clinical trial, we will say, let's define first what's the mean by the bias in context of the clinical trial. Bias, it's a systematic review that can distort the true effect of intervention and lead to incorrect conclusion. Unlike random error, which can cancel over time, bias is squeezed like a squeezed result in particular direction. For example, if the study have selection bias, the group being compared may be not similar enough as a baseline. This will be leading to mispresentation of the treatment effect. So the understanding of the bias is critical because it's help us to critically evaluate research finding and ensure that healthcare decisions are based on accurate and reliable evidence. So to start to define what the mean of the bias in the context of the clinical trial, bias, it's like a systemic error that can distort the true effects in the intervention. What I mean, and that can lead to incorrect conclusion. So unlike the random error, which can cancel over time, bias squeeze result, particularly direction. For example, let's say if a study have a selection bias, the group being compared may be not similar enough to the baseline. So that may lead to, as we said, misinterpretation of the treatment effect. So understanding bias, as we said, it's critical. We have to be careful of that. We have a lot of type of the bias in the clinical trial, starting with the selection bias. What's the meaning of the selection bias? Selection bias, basically, its mean occur when there are a systemic difference in characteristic of participants assigned to each group. And this can happen if the randomized method are not truly random. It's not implement. Or the participant influence to assign process. So that may lead to the selection bias. For example, if the healthier individual are more likely to be planned in the treatment group, the result could falsely suggested that the treatment is effective. So to prevent this selection bias, we will use a random sequence generation to make sure that assigned participant allocation randomly, and to ensure that no one can predict or influence in group assessment. Additionally, it is essential to strictly adhere eligibility criteria to make sure there is random allocation. We have also what is called the performance bias. Sorry. So we have the performance bias also. What's the performance bias? It's type of bias when there are a difference in care provided in participants beyond the intervention itself that can occur when the participant or the healthcare provide know who received the treatment and who is receiving the placebo. This knowledge may lead to different behaviors, such as providing extra care or supportive to one group. So let's say, for example, if nurses know which patient are in experimental group and they are giving them more attention, potentially that will be lead to potentially affect outcome. So to minimize the performance bias, we use blinding technique, which neither participant nor personnel know which group the participant belong to. So we also standardize care in the protocol to ensure all participants receive same level of care, regardless of the group. We have something else also called the detection bias. Detection bias occur when the method of the measurement outcome differ between the group. This type of bias is particularly concerned for subjective outcome, such as pain, quality of life, where the expectation of the outcome can influence their judgment. So what we can do here also, we can do blinding outcome for the assessor, can influence their judgment. Blinding outcome is one of the most effective way to reduce the deduction bias. Additionally, we can use the objective measurement whenever possible. It will help to ensure accuracy. For example, instead of rely on subjective pain assessment, we may use a Fallot pain scale. So here consistently in data collection method and the use of reliable measure tool are also critical to minimize this type of the bias. We have something also called attribution bias. This type of bias when unequal drop of the participant across study group. So this how can affect the study? This can affect the dropout of the participant across the group, can affect the result, especially of those who drop out have outcome, and those who is remaining. So that especially if they have the outcome and they drop off the study, that may give us the wrong result. So how we control the dropout? For example, let's say we have participants experience severe side effects are more likely to leave the study. The remaining participant may be given a false impression of the treatment safety. So the best way to manage this type of bias is to mitigate this attribution bias. We use attention to treat analysis, which include all participants in the analysis, regardless whether they are completed the study. Additionally, implementation retention strategy, such as a frequent reminder, or maybe I offer something for them so they can stay, or at least if I cannot keep them, I keep the reason of the dropout. So this strategy can be used to reduce this type of the bias. And here we have the sum mutation strategy for common bias. As we said before, we use the random sequence generation to address the selection bias. We use random section generation to ensure that assignment are truly random, and allocation concealment to prevent any influence over the process. And as we said, for the performance deduction bias, we are immediately through the blinding and use the objective outcome measurement. And to handle attribution, as we said, the best way is intention to treat analysis to minimize this type of bias. And this strategy not only to improve the reliability of study results, but also enhance the ethical standard of the research. We have tools used to assess the bias. So we have several critical appraisal tools that are available to help assess the risk of bias in clinical trial. One of them, the chronic risk of the bias tool, is widely recognized resource in systematic review. It's to evaluate the key domains such as randomization, blind, outcome data handling, the assignment in each domain risk level. Critical appraisal, we have something also called critical appraisal skills program. It's another a practical tool that can be used like a checklist format to make sure that the systematic or the randomized clinical trial. And by the way, if you have a systematic trial or systematic review, you have to go through the study inside and do individual evaluation for each study to make sure it's what's the type of bias include, and then you will evaluate the whole systematic review. Okay, and this is how the tool can be used. You can go to the tool and read the checklist and follow the instruction. We have also additional type of bias in trial design. Certain type of clinical design introduce unique bias. We have something called the cluster trial, where a group rather than individual are randomized and can suffer from false precision if the analysis did not account for a group level variation. Similarity, we have a crossover trial where the participant receive more than one intervention in sequence may have carried out the effect from the one phase because they are switching. But we have a type of bias special in this design called carryover effect from one phase. Managing these bias required specialized statistic method and design consideration, such as a wash-out period in crossover trial to eliminate the residual effect, ensuring that the trial design is appropriate for the research question and for obtaining the reliable results. For ethic and bias clinical trial, we have make sure or ensuring that the study are free from the bias. It's not just a methodological concern, but it's also ethical obligation. Participants have the right to receive unbiased information about the study, and when they are joining, ethic committee play a critical role for reviewing study protocols. And for the bias in the future direction, we cannot offer it can lead over the underestimation of the treatment effect, which turn the influence of clinical decision-making affect the patient care. when bias studies are included in meta-analysis, they can distort the overall conclusion. يعني we have to be careful. Even we have a meta-analysis doesn't mean that we can rely on the result. We have to go through each study and do the evaluation. And as a conclusion of all of this, we have to warm up and minimize the bias in the critical mixture of the validity, reliability of the randomized clinical trial by employing methods like blinding, allocation concealment, and make sure to use a right statistical analysis. We can ensure that findings are both accurate and applicable to real-world setting, while challenge remain in advanced bias management. But يعني, we just try to do our best to minimize, and there is a merge of error, it's acceptable, but there is merge, it's not acceptable. So we have to do our best to make sure there is unbiased research, because the unbiased research, it will be improving the healthcare outcome and ensuring that our study provide truthful evidence for the clinical practice. Thank you for your time, and I will look for your question or discussion. Thank you.
Uncomplicated cholelithiasis by laparoscopic cholecystolithoextraction. In terms of the number of surgical interventions, laparoscopic cholecystectomy consistently occupies one of the first place in modern surgery due to the widespread dissemination of laparoscopic technologies, relatively good immediate results of surgical treatment, the possibility of delayed operations, including cases of acute cholecystitis, as well as a small number of contraindications to this surgical treatment. But the concept of organ-preserving operation is based on the minimally invasiveness of surgical interventions and had always been welcomed in the scientific world. At the same time, the use of organ-preserving interventions for cholelithiasis with an unchanged gallbladder with preserved motor evacuation function is not widely used, although publication of the implementation of such interventions in some clinics can be found in the literature. The aim of the scientific work was to determine the possibility of carrying out endoscopic methods for removing stones from the gallbladder while preserving the bladder itself, laparoscopic cholecystolithoextraction, as one of the methods of treating uncomplicated cholelithiasis. Organ-conserving operating for cholelithiasis due to the preservation of the bile outflow mechanism do not lead to an increase in the load on the sphincter of Oddi and can be considered as a method of preventing of post-cholecystectomy syndrome in the postoperative period. Under post-cholecystectomy syndrome, we considered all cases of the development of postoperative complications, including dysfunction of the sphincter of Oddi, as well as the development of disease of the hepatopancreatoduodenal zone. In the Republic Center for Functional Surgical Gastroenterology, Krasnodar, in 2004-2006, endoscopic methods removal of stones from the gallbladder with the preservation of the bladder have been developed and implemented. The technique of endoscopic organ preserving surgery in the presence of stones in the gallbladder, laparoscopic cholecystolithoextraction, consisted of opening the lumen of the gallbladder using standard laparoscope access, its revision using a kaleidoscope, removing the stone, followed by suturing the cholecystostomy wound and preliminary double external drainage according to the method of an operative AV. Based on the results of development in 2007, 2 inventions were registered and 2 patents were received related to organ-preserving operations for gallstone disease. The gallbladder cavity during surgery and in the early post-operative period was washed with a solution containing furacillin, chymotrypsin, and hydrocortisone. The need for lavage was due to impact on such mechanism of the development of cholecystolithoextraction as inflammation, hydrocortisone 0.5%, infection factors, furacillin 0.02%, decreased protein concentration in bile, chymotrypsin 0.2%. In our cases, for the endoscopic removal of stones from the gallbladder, a special device has been developed containing a tubular body with a handle and a tube placed inside with an endoscope installed inside with petals on the working stone, which are installed with the ability to compress when enter the body. A tubular rod is placed inside the tube with the ability to connect a suction system. The technical features of the invention make it possible to capture stones with petals under the control of an endoscope, crush large stones with rigid petals, and remove small stones using a suction system after removing endoscope. In the period from 2004 to 2008, under the leadership of doctors of medical science and operative AV and head of the endoscopic department, Gabriel S.R., 12 surgical interventions were performed at the Republican Center for Functional Surgical Gastroenterology. In the study, all patients were female, aged from 19 to 57 years. The average age was 41.7 years. In patients undergoing surgical intervention, ultrasound examination revealed from 1 to 3 stones with a diameter of 8 to 20 millimeters. The average stone's diameter was 13.9 millimeters. Mandatory conditions for organ-preserving surgical interventions were presence of preserved contractile function of the gallbladder, absence of inflammation of the gallbladder wall, average size of the stone, allowing them to be captured and removed from the cavity of the gallbladder while maintaining its anatomical integrity. No signs of sphincter of Oddi dysfunction. The patient does not have gastric and duodenal ulcers or visible pathology of the major duodenal papilla during endoscopic examination. No signs of the presence of stone in the biliary tract. Absence of previously established liver and pancreas disease. The patient desired to undergo organ-conserving surgery despite the risk of relapse. Surgical interventions were carried out mainly in the period from December 2006 to September 2008. Later, during the reorganization and subsequent closure of the Republican Center for Functional Surgical Gastroenterology, the performance of laparoscopic cholecystolithoextraction was stopped. But for some time, we continued to monitor the operated patients. One of the 12 patients, 9 noted minor periodic pain in the right hypochondrium before surgery, dyspeptic disorders, but 3 patients focused on the presence of pain. It was in them that recurrence of stone formation was noted in the future. Patient once measured the size of the gallbladder on an empty stomach, followed by giving a choleratic breakfast and remeasurement of its size. The presence of preserved contractile function of the gallbladder more than 50% was one of the main criteria for selecting patients for laparoscopic cholecystolithoextraction. For the selection of patients, the absence of previously established chronic pancreatitis was also taken into account, as well as the normal size of the pancreas, oncogenicity, and contours of the organ were not taken into account. The early and the late postoperative period in all 12 patients proceeded well. However, in one patient, after 1 year and 3 months, an exhibition of chronic pancreatitis was recorded after taking melon, which requires hospitalization. No evidence of cholelithiasis was found in her. The first follow-up examination of the patient was conducted in the period from May 2009 to January 2011, in the period after the operation, respectively from 8 months to 5 years and 4 months, average 2 years and 2 months. The earliest follow-up examination of the patient, 8 months, was caused by the appearance of pain in the epigastric region and an independent ultrasound examination of gallbladder on which stones were detected. Ultrasound examination of the liver, common bile duct, portal way did not reveal any abnormalities in any of the group of patients. Especially valuable is the absence of expansion of the common bile duct in operated patients, which usually occurs after cholecystectomy performed by any of possible methods, open, laparoscopic, mini access. The contractility of the gallbladder after laparoscopic cholecystolithoextraction, despite the line incisions of the gallbladder wall, remained at a fairly high level in all patients undergoing surgery, ranged from 42% to 91.2%, on average 67%, which indicated a low trauma and minimally invasive surgical intervention and preservation of motor evacuation function of the gallbladder after surgery. Patient care had 5 stones up to 8 millimeters in diameter, postoperative period 8 months. Patient S, 2 stones, 4 millimeters, postoperative period 2 years and 4 months. Patient H, 2 stones, 11 and 12 millimeters after 5 years and 4 months. The average growth of stones in operation patient was 5.3 millimeters per year. Starting from 2011, due to the reorganization and subsequent liquidation of the Republican Center of Functional Surgical Gastroenterology, monitoring of patients was discontinued. In 2023, we established contact with patients in whom, during the first control examination, hyperoic suspension was identified, or there were no stones. Second control examination, average time 15 years and 6 months after surgery. Of the 9 people, no stones were detected in 3 patients. Laparoscopic cholecystectomy was performed in 3 patients in 2013, 2021, 2022. The connection with 3 patients could not be established. Patients who did not have a relapse of the disease, 3 patients were examined. No clinical or ultrasound signs of post-cholecystectomy syndrome were detected in them. In our study, we did not encounter cases of dissatisfaction in patients with the organ-preserving intervention and the need for laparoscopic cholecystectomy in case of relapse of the disease. On the contrary, all patients who were invited to participate in the study almost without hesitation agreed to participate. Conclusions. Based on the results of the analysis of the immediate and long-term results of laparoscopic cholecystolithoextraction, some preliminary conclusions can be drawn, recognizing the higher error in the result obtained due to the small sample. Laparoscopic cholecystolithoextraction can be considered as a method of treating cholelithiasis, since no complications of the disease from this method of treatment were identified. All operated patients were warned about possibility of recurrence of cholelithiasis. If stones appeared, they removed the gallbladder from the same surgeon who performed before laparoscopic cholecystolithoextraction. All operated patients require obligatory dispensary observation. In 3 patients at the first control examination, a recurrence of cholelithiasis was detected in an average of 2 years and 2 months after the operation. In 4 patients, there was congestive echogenic bile in different amounts. Violations of the mode of evacuation function of the gallbladder after laparoscopic cholecystolithoextraction is not observed. On average, it was 67% at the first follow-up examination after surgical treatment. Expansion of the common bile duct was not observed in any of the operated patients, which indicates the normal functioning of the sphincter apparatus of the biliary tract in the post-operative period. In the study, we noted a clear correlation between the pain syndrome reported by patients before surgery and subsequent development of cholecystolithiasis recurrence. 3 out of 3 patients, however, given the small sample size, it is premature to draw any conclusions. A special device developed at the Republican Center for Functional Surgical Gastroenterology in 2006 allows capturing stones under visual control, crushing large stones, and removing small stones using a suction system. The average growth of recurrent gallstones in our study was 5.3 millimeters per year. Perhaps in the cases of dynamic monitor of these patients before operation, we would have noted the growth of stones in their unoperated gallbladder. There was a certain trend between the number of stones detected before surgery and the development of cholecystolithiasis in the post-operative period. At the first follow-up examination among patients with 1 stone, recurrence developed in 1 case out of 7, 14.3%. In patients with 2 or 3 stones before operation, stones reappeared in 2 cases out of 5, 40%. According to the results of the study, it turned out that at least 3 out of 12 patients, 25%, subjected to laparoscopic cholecystolithoextraction did not have a recurrence of stone formation 15 years after surgery, despite the lack of dispensary follow-up. Undoubtedly, the percentage of favorable results can be improved with proper postoperative management of patients. Based on the results of the study, we can conclude that it is possible to carry out organ-preserving interventions for cholelithiasis with a high risk of developing post-cholecystectomy syndrome in patients with cholecystolithiasis. We continue our work to study the course of the disease and predict treatment outcomes in patients after surgical treatment of cholelithiasis. Thank you for your attention.
Between medical and surgical service in breast cancer across Hamad Medical Corporation in Qatar. I have no conflict of interest to declare. My agenda for today will have a background. The objective for this study was done as a quality project. Communication barriers, methods, outcomes, and conclusion. So there are several communication strategies in healthcare that can be adopted to improve communication and to ensure efficient exchange of information. As our practice at Hamad Medical Corporation, we have ISPAR communication, and this ISPAR is founded in Cerner, which is a medical record for us, and it is as a type of handover communication. So what is the meaning of handover communication? It is an interactive, verbal, written, electronic communication of a process of passing current, accurate patient's information along with the authority and responsibility from one caregiver or care setting to another to ensure continuity of care, effective and timely communication, and to maintain patient safety. So improvements to communication between all members of the care team and communicating more effectively with patients can greatly improve the patient's experience. On the other hand, the poor communication increases the potential for medical errors, creates a negative working environment, and increase the cost of healthcare profession. Also, poor communication translates into a lower quality of patient's care, which will have a negative effects on clinical outcome. And there is a supportive studies done at U.S. San Francisco University in 2016 discovered more than a quarter of hospital readmission could have been prevented if there had been more effective communication between healthcare providers and patients. So the objective of our project are to enhance the communication process between the healthcare providers at breast cancer service in Hamad Medical Corporation, to establish a well-structured electronic database for neoadjuvant patients who are receiving chemotherapy before the surgery with locally advanced breast cancer, to improve the quality of care provided, to improve patient satisfaction, to follow Qatar National Cancer Program guidelines. So based on our national cancer strategy, patients diagnosed and discussed in the multidisciplinary meeting must deliver the first treatment within 14 days from diagnosis of locally advanced breast cancer and the initial treatment of locally advanced breast cancer in the systematic treatment. So we create this project to enhance our communication to keep deliver treatment for patients within time frame. Basically, as we are specialized care, we are communicating with whom? As I am a clinical nurse specialist, I will communicate with the medical oncologist, a breast surgeon, and other clinical nurse specialists from my team and from the breast surgery team, patients also, to provide a holistic care for patients. As we saw in the previous slide, we are communicating and working with a multidisciplinary team. We have noticed a couple of barriers in communication that will affect links between the team members. So for our cancer patients require frequent hospitalization for multiple reasons related to the nature of the disease and the complexity of a treatment. During their admission, they are handled by multiple physicians, like we have medical physician, surgeon, radiation oncologist, etc., and healthcare provider. So we should have maintaining good communication among physicians and the team is an important issue to be monitored and improved. Miscommunication may compromise the level of quality of care provided to our patients. Among the possible identified causes of this problem was the absence of a standardized tool to be used by physicians to facilitate communication and be used as a documentation tool for the communication process and treatment plan. So, to reduce the communication barriers, now the question, do we have a standardized structured message? Before starting our strategy, we should formalize our team to standardize our message. First phase, to standardize the message, we need to identify all of the stakeholders, which include clinical nurse specialist, medical oncologist, breast surgeon, radiation oncologist, and patients pathway coordinators. In the second phase, stakeholders analysis is an effective process for prioritizing the problem, recognize the gap and the challenges. After that, all stakeholders work to improve these gaps and look for solution and agree to implement the plan. In the last phase, which is role play and training, each stakeholder has a specific rule to apply for improvement and get the proper training to apply and establish the standardized communication. So that we will establish an effective communication. So for our project, we use the rapid cycle improvement plan, do, study, and act methodology to test and evaluate the new communication process tools. Here, as in the 4 phases, we'll start with the plan. We are establishing electronic communication forms shared in iTawasul workspace, which is an intranet website across Hamad Medical Corporation, to monitoring the compliance among physicians weekly. In do phase, the electronic communication form was developed by the breast cancer team, and then physicians' feedback was obtained. The section head explained to the team the components of the communication, from the purpose behind it and when and how to use it. In the study phase, according to the physician's feedback, the form was very helpful in the prioritizing patient's care. There was some misunderstanding about the communication points and acknowledgement between the team. In the act phase, which is the final phase, the section head support was needed to emphasize to physicians to complete the form on time and to keep it updated. To recognize and to organize the communication between breast cancer service, we create the folder. This folder is available in the shared folder in iTawasul at Hamad Medical Corporation's intranet. So all press team has access to this folder, and we can download it from any computer at Hamad Medical Corporation. In the first page of this folder, we found the patient's list of the new adjuvant breast cancer patients. We have the patient's name, health card number. This list is filled by medical oncology clinical nurses specialist. And here how it is look like in a shared folder. Here you can see it. This is patient's name, health card number, who's the primary clinical nurse specialist, the medical oncologist, breast surgeon. And this is how it's look like in the share folder. This is in the home page. Include all this information. And this information should be filled in by clinical nurse specialist. Here, how it's look like the patient's record. In the left side of the screen, we can see the preoperative treatment plan. This form will be filled by medical oncology clinical nurse specialist. We can see patient's name, health card number, diagnosis, including hormone receptors, chemotherapy protocol, the first cycle of chemotherapy, expected date for last cycle of chemo, the medical oncology clinical nurse specialist, the primary medical oncologist, the pathway coordinator, other comment. If we need to add, like patients need MRI for spine or CT scan. On the right side of the monitor, we can see the initial staging and restaging. Down, we can see the post-operative treatment plan. In this part, the breast surgery clinical nurse specialist and breast surgeon radiation oncologist need to review the file. In conclusion, by using a well-structured form and method of communication, we were able to improve the communication process among breast oncology physicians and surgical service, developing a handover form to be used as a communication tool is a useful approach, and it will be reflected positively in many aspects of the healthcare process, such as improving patient safety, increasing physician satisfaction. Thank you.
The topic that I will present today is a very elusive topic that is hardly spoken about, but as you will see, it has immense implications on quality of care. And my goal is to raise your awareness as people who are researchers, doctors, people who are engaged with health systems in your countries. So thanks for advance for your listening. Our topic today is perpetrated sexual harassment against clinicians, especially female clinicians, and its effect on well-being, coping, patient safety, and quality of care. What is the prevalence and what can we find about sexual harassment against clinicians? So the Medscape reports that are coming out every year paint since 2019, the beginning of the COVID pandemic, a very grim picture regarding the phenomena of sexual harassment against clinicians, indicating that it's a very troubling occupational risk, especially in hospitals. And one of the problems is that this phenomena is rarely acknowledged, making it very elusive and a very touchy subject, especially for the clinicians. To date, sexual harassment against clinicians has remained untouchable, hardly studied, untreated, despite its known implications on the well-being of nurses, of doctors, and the implications on patient safety. 55 to 98% of nurses reported that when they are sexually harassed, they miss nursing care. Missed nursing care is a very fundamental concept in audited nursing. It is usually supervised, and it refers to any aspect of treatment or required patient care that is omitted or delayed or left unfinished, and that is unintentionally, of course. Missed nursing care is universal. It happens across medical settings, across countries, across cultures, and it threatens quality of care and patient safety. From studies that we performed, at least one nursing task was missed following a sexual harassment. Thus far, the antecedents of missed nursing care were, for example, ineffective team interactions, excessive workloads, poor deployment of personnel. We know that there are shortages everywhere we looked in terms of medical personnel, deficient flow of care, maybe the stress in the work environment, but we found that sexual harassment against clinicians is a new antecedent that wasn't acknowledged till now. And it creates unsatisfaction in the work environment. It affects clinical outcomes, patient satisfaction, and it increases turnover of personnel. To minimize missed nursing care and improve the outcomes, what hospitals usually do is proactively manage personnel. They manage admissions, they train staff for better teamwork, but they ignore sexual harassment, which is a very strong, newly acknowledged, because of our studies, antecedent of missed nursing care. What I present now is two studies and the insights from two studies. One was a qualitative study, and the other is a quantitative study. The first study was qualitative. It was a study with a hidden population because of the sensitivity of the issue of sexual harassment perpetrated by patients against clinicians. What we did, and it was during the Me Too movement, we asked in the social network of the health systems, we asked for letters from nurses who were exposed to such harassment. And we were just astonished because it was a Pandora box. We received 50 letters from frontline nurses. These 50 were just from frontline nurses. We received hundreds of letters. We analyzed them using the 6 steps of Aronson's thematic analysis. That was the qualitative study. We didn't expect such an outcome of hundreds of letters, secretive letters, nurses and female clinicians who were embarrassed and felt ashamed, but they sent us the letters. The second study was following, that was a quantitative study with yet another rare population of ultra-religious nurses, Muslim and Jewish religious nurses. The sample comprised of 85 religious nurses, and I'll read a few quotes from the qualitative study that opened up this Pandora box to this very important topic. And the female clinician says, the patient sat on the examining bed. I crouched underneath and checked his calves for edema. And while he looked down at me and told me how lonely he had been since his wife died and how he would be happy to find a female, he looked with a creepy smile directly into my eyes and repeated this twice. Second quote, I had to insert a catheter for a 78-year-old patient. His son asked to stay with his father during the procedure. His father agreed, and so did I. I explained every stage of the procedure to the patient. I apologized for touching his private parts, and his son said, why are you apologizing? Go on, let him enjoy it. I hesitated, says the physician. Should I stop? Should I call a nurse? but I didn't. I finished the examination quickly and left the room. In retrospect, I discovered that I had forgotten to do some things I should have done. So nurses and clinicians felt that there's this implicit expectation by their managers and peers to continue the procedure as if nothing happened. Nurses especially reported negative attitudes of colleagues and lack of support from the ward managers. Because the patient was weak and perceived as unable to sexually attack the nurse, their peers and ward managers belittled and discounted their upsetting experience with dismissive actions. For example, they said, "He doesn't have the strength. Now really, what can he do to you?" Or, "He's sick. He'll forget tomorrow, and so will you." So such responses created a value-based conflict among nurses, because on one hand, they were responsible for the patient's outcomes. On the other hand, they felt insulted as professionals, as females, and as human beings. They wrote that the experiences, especially with their peers and ward managers, made them reluctant to share their experience or to report the incident to their managers. The goals of the quantitative study was to examine the extent of exposure to sexual harassment at work, to test the ward's climate of listening to patients, test the quality of nursing care that is provided to harassing patients, examine the avoidance of therapeutic contact with the harassing patients, and to see if there are differences in socio-demographic data, although literature on violence against clinicians, for example, says that nothing matters. The geography, the culture, it happens everywhere, and it's an epidemic. So the dependent variable was quality of care. The independent variables were exposure to harassment, ward's listening climate, and avoidance of therapeutic care. What were our findings of this study? Patients did act in an overtly sexual manner, try to touch, grope, or rub against a nurse. The prevalence, you'd be astonished, 60% of female nurses and 34% of male nurses worldwide report a sexual harassment incident. In another study, 70% of nurses experienced harassment. 40% of them, they were considering leaving nursing because of the abuse. Findings. Following the incidents of sexual harassment, nurses reported that they had headaches, fatigue, insomnia, and stomach pain. Sexual harassment was negatively associated with clinical outcomes, reported clinical outcomes of the patients. And although nurses experienced the incidents as very upsetting, 77% of hospitals didn't investigate the incidents, and only 45% of hospitals provided training to the nurses on how to better cope with sexual harassment from patients. We performed a multiple regression analysis to reveal what are the antecedents of quality of care to the harassing patients. We found that the more the nurses were religious, the more they avoided the therapeutical contact with the harassing patients. They also wouldn't talk about it. They wouldn't share it with their friends or their spouses. The avoidance of therapeutic contact was the strongest predictor of reported quality of care for the harassing patient. 42% of the variance in reported quality of care was explained by the type of employment, the avoidance of therapeutical contact, which was related to the religiosity level. That was the third antecedent of quality of care. So when we look at both studies, 6 themes emerged. 1, nurses felt objectified and that the very sacred patient nurse therapeutic space was desecrated. They felt lack of support from their managers. They felt unprotected, lonely, and alienated. They didn't share the experience with their managers. They coped by ending the treatment as quickly as they could, and later realized that they missed very important tasks. And lastly, they considered leaving the profession. What can we learn from this study? So there are many insights, and if any of you can take the message home to your health systems, that would be wonderful. What we did, our studies pointed at sexual harassment against nurses as a new antecedent of missed nursing care that inhibits patient safety, inhibits patient-centered care, and jeopardizes clinical outcomes. This newly discovered antecedent calls upon management to raise awareness to the mechanisms by which sexual harassment relates to missed nursing care and patient safety. If we raise awareness, if you help me raise awareness, it will enable hospitals to cope more effectively with missed nursing care and with turnover of nurses. And there's a paradox in this phenomena. The paradox is that while hospital managements aspire to strengthen the voice of nurses, and they always say, we want nurses to voice their opinions and tell us what they think, they are silent about sexual harassment against nurses. This is a strong discrepancy between this aspiration and declarations and the failure to take action to address the impact of sexual harassment on nurses and on missed nursing care, on patient safety, and on clinical outcomes. What are the implications? There are implications for policymakers, for management of the nurses in the wards, and for management in the hospitals. Policymakers, they're called upon to adopt 8 steps for effectively coping with sexual harassment. In the studies, you look up Gili Gabay missed nursing care or sexual harassment, and you'll see the details of the 8 steps that policymakers can take to reduce sexual harassment and missed nursing care. Nursing managements are called upon to modify their management style, enhance listening to nurses, provide support to nurses that experience or witness the sexual harassment, alleviate their stress, and reduce missed nursing care. Leaders of nurses must raise awareness of sexual harassment, develop policies, implement the policies, and also provide training, especially for religious nurses, because it takes a different cultural sensitivity to accompany these religious nurses. Policymakers should also differentiate between the classic antecedents of missed nursing care that I elaborated before, and between antecedents of missed nursing care that results from patient misconduct. So yes, we are there to provide care to patients, but we need to realize when patients act with misconduct, we need to set boundaries and communicate with those patients or their families. Practice implications for hospitals. Hospitals must recognize sexual harassment, although it's difficult to speak about it, it's elusive, it's very sensitive, but they must recognize it as an antecedent of missed nursing care. They must reduce missed nursing care that results from sexual harassment by interventions to support nurses and counteract the negative outcomes of sexual harassment and missed nursing care. Nurses must be supported after sexual harassment. Work environments must be safer for nurses and female clinicians. There needs to be modifications in attitudes of management and of peers, and listening to patients and to nursing came out as a strong contributor, explaining the variance in therapeutical contact and in less missed nursing care. So what can management do? Encourage open dialogues, legitimize discussions on sexual harassment, and modify their management style to enhance their listening. To deal with missed nursing care, excuse me. Okay. Implications for ward managers. Consider the loneliness that nurses feel and the alienation following harassments. Consider how it affects their work, their performance, their ability to communicate with patients. Conduct monthly training for acquiring self-efficacy, for knowing how to better cope with sexual harassment and how to assertively set boundaries for patients. And this is something that I was working with nurses about, because nurses said, well, this is just a part of our job. What can we do? No, this is not a part of their job, and they need to assertively set boundaries to reduce this from happening. Provide multiple response options for nurses to resolve the tension between their caregiving role and being able to cope with sexual harassment. Yes, you have your role as a nurse, and when this happens, you need to set the boundaries, although you are a caregiver. Enable nurses to be engaged, review surveys about these incidents, and craft interventions to reduce sexual harassment that will reduce missed nursing care. Also, for ward managers, shape an organizational culture in the ward of higher safety, higher openness, work on the resilience of nurses as ways to reduce missed nursing care. Hospital managers, what can they do? They can appoint professionals to support nurses throughout the processing of the harassing incident. Also, initiate a campaign for the community so that they raise awareness of patients and their families to the implications of sexual harassment on their loved ones. When they act this way, it means that they will encounter missed nursing care that can be very dangerous and jeopardize their safety. If families know that, maybe they will not collaborate and set boundaries to the patients. Build a computerized reporting infrastructure. Since this is an elusive topic, there is no collection of data about it in hospitals. There is no infrastructure to track data. If we have a computerized reporting system, we can track the data, know when the incidents happen, where they happen more, what are the behaviors, what are the times, what are the frequencies, and be able to monitor how we progress towards a much safer work environment for nurses and female clinicians. Also, promote cooperation among the support team, the management, and security officers. Design a brief procedure for filing complaints in the police against sexually harassing patients and their accompaniers. And the last thing is, oh, hold on. The last thing is that we all need a very strong initiative in our health systems with joint efforts of all stakeholders in order to reach the desired change of preserving the sacred therapeutic contract, the well-being of nurses, the safety and high-quality nursing care. The effective coping with sexual harassment and assuring a safe work environment is really a must, and it's a responsibility of the ward managers and the hospital managements. And together we can reduce this phenomena of missed nursing care. If we raise the awareness of the scope of missed nursing care and the high danger that it entails, we can improve the teamwork, we can create supportive networks in our hospitals and contribute to nurses' well-being and retention. So thank you so much. Please feel free to contact me with questions or research that you maybe would like to perform in your country and your health system. So let's open it up to a discussion, to questions, whatever you see fit.
Country, and we have a lot to do with the patients and the problematics of financial toxicity, mostly in the hematology. So what is like definition financial toxicity? It will be the problem of a patient that he has in the cost of the medical care. This is the definition by National Cancer Institute. And normally it's a new term or a new name for a growing problem. And this is created to describe probably the objective financial burden from cancer care, including the associated psychological distress of the patients and the coping behaviors utilized by those patients and also by the caregivers. But we have a lot of terms when we speak about financial toxicity, because the problem itself, it's not new. We have the financial toxicity known as financial distress, financial stress, hardship, financial burden of cancer, economic burden and economic hardship, or sometimes economic and financial burden and economic suffering. So in everything at all, the individuals diagnosed with cancer have to deal with the financial stress because there are a lot of money, emotional stress, mental stress, and physical stress, all in the same patient or in the same patient. When we say that, well, you have diagnosed with a cancer, and we have also hematological malignancies. When we face the hematological malignancies, as you see in the screen here, I'm trying to make a laser point. Okay, here you see an increase in the incidence and also in the death. And when we speak about those hematological malignancies, we speak about a group of diverse diseases that are diverse not only in the biological context, but also in the clinical context. And they affect the people of all the ages, from children to elder people. And it compounds about 9% of all malignancies in Europe and the United States. In the GlobalCan survey made in 2022, it was there were diagnosed with non-Hodgkin lymphoma about 553,000 new cases, and half of them there were dead, and also was diagnosed about 500,000 of cases with pathological malignancies, but also to see this financial problematic they present. Because when a doctor says that, well, you have a cancer, the patient minds go enter in the complete shock, and they are thinking mostly how serious it's, how terrible is this disease, what can I do with this disease, mostly how long do I have to live, and so this compound this physical, mental, and emotional stress. But if you lack of money, sometimes you have this financial stress, and we are speaking about this financial toxicity. And to tell the truth, patients shouldn't have to ask how much it will cost, because the treatment for the patient with cancer, in my opinion, should be not so high in prices. If we speak about treatment costs in hematology, I present here an article about the costs associated with hematopoietic stem cell transplantation. And as you see here, it was a study made in Germany, and among 258 patients with hematological stem cell transplantation, the cost was about 300,000 euros per patient when we speak about acute lymphoblastic leukemia, pediatric acute lymphoblastic leukemia, and quite almost the same also in adults, also in diffuse large B-cell lymphoma, and a little bit less when we speak about autologous bone marrow transplantation in diffuse large B-cell lymphoma and follicular lymphoma. So it's highly, the costs are high, and when we speak about CAR T-cell, that is the new therapy, the new era of treatment of these patients, the cost for infusion, it is about 373,000 to 574,000 for infusion, excluding the extra procedures or facility costs those patient needs. And when we face CAR T-cell therapy, we have also the cost of treating those complications, it's about 56,000 per patient. So mostly in the total, the treatment cost for CAR T-cell therapy in the patient that really need it, that are suffering from malignancy, hematological malignancies, it's about of $500 for patients with severe collateral adverse effects. So if we see about this financial toxicity, as you see in this slide, it's all about out-of-pocket costs and the loss of productivity. And we have to keep in mind also a patient-reported outcome that can be affected by many variables, like insurance or coverage of the payment. We have to keep in mind the geographic location where the patient lives, or the cultural and personal factor of this patient. All we should keep in mind when we speak about financial toxicity. And most of the patients that are undergoing cancer treatment experience higher rates of personal bankruptcy, have a diminished ability to build savings, and acquire assets due to financing unexpected medical costs they face. Also, they can have long-term career implication, because due to the chemotherapy or cancer treatment they have a decreased productivity, unwanted changes in the jobs and responsibilities, and sometimes they need this prolonged period of time away from work due to this cancer treatment, long cancer treatment. So this is the main factors that the patients have this personal bankruptcy. And also they culminate when we have the survivors, because they have lower asset ownership, they have more debts they face, and mostly that's seen in the people that are middle-aged. But what are the other factors that contribute to the financial toxicity in the cancer patients? First of all, as we said, they are maybe not able to work because they have challenges during the treatment and the recovery. Sometimes they have a lack of health insurance or inadequate health insurance to cover all the treatment. And as is said in the study published by Harris Fool in 2016, although some people with cancer may be able to use some savings to cover expenses, studies have shown that 31% of customers have no retirement savings, and this we have to keep in mind. And most of all, in one side, we have the cancer treatments that are really expensive, and on the other side, we have the insurance coverage that is often inadequate for those patients and made this financial toxicity. Another thing we have to keep in mind is the patient perception, because between 15 to 59% of patients experience a financial burden because it was out-of-pocket expenditure due to clinical appointment, prescription and non-prescription medication, and also the travel, because for some treatment they have to go abroad. And this was associated also with worsening quality of life and living, mostly in the people who live in metropolitan areas. And to tell the truth, it's not evidence that this can impact the survival, even though there are some studies, they say that we have, for the patient who have or face this financial burden, have a reduced quality of life, have a lower satisfaction, have also reduced medication adherence and reduced overall survival, as is published in current oncology in 2022 by Parker. And here is a schema presenting that what I said, what are the patient-reported financial toxicity that are direct cost, indirect cost, patient-specific values, expectations, and individual economic circumstances. We have to keep in mind one point of concern about the impact of financial toxicity. Patient often delay or forego all forms of medical care, including, for example, office visits, prescription of the drugs, and mental health. So the financial toxicity impacts the delivery of care. Also can impact the inequity in clinical trials, clinical trial participation, because patients are younger, poorer, non-white patients may not have those good insurance or may not be able to participate in these clinical trials. And if we don't have the delivery care, and if we don't have this equity in the treatment of this patient, we have an impact also in overall survival. Sometimes patients, due to the lack of money, are not adhered to the medication. They skip appointments, and sometimes they need to cut back on these basics like food, clothes, and shelter, impacting also the health. And sometimes they use also the retirement savings, and this impacts the life of them. About the prevalence, if you see here, the direct cancer cost and the cancer patients are about billions. We are speaking about billions of money spent. And this is the cost of cancer care in the United States, evaluated in the year 2020. And if we assess the prevalence and the related factors on this financial toxicity in the cancer patients, based on the cost scale, because we have measurement scales, it's seen that nearly half of patients with cancer are experiencing financial toxicity, and half of patients, it's not a good sign. And also, the financial toxicity was also affected by gender, age, the type of cancer, the region of the patient where he lives, and also during the COVID-19 pandemics. 36 million of American adults did not fill a prescription in 2016 because of the cost. And in this study, 42% of participants reported a significant financial burden. So we cannot afford not to be treated. And so this is the point we have to face, the point of care. We must treat those patients. And if half a patient experience this financial toxicity and avoid also 36 million of Americans did not fill prescription. This is really hard because they suffer a lot and they can probably die. Normally, cancer will cost all the world about 25 trillion over the next 30 years. This is an analysis reported between the 2020 and the 2050, according to these 29 cancers in 204 countries studied. And here in the left side of the screen, you see all the blood cancers, acute leukemia, chronic leukemia, bone marrow disorders, lymphomas, and multiple myelomas, and also all the spending every patient has to pay. And it's going worse and worse. So we have to keep in mind that prices are going higher and the risk of financial toxicity also. Cancer expenses are rising due to aging population because more people with cancer require treatments, innovations, but they are really more expensive compared to the others. And sometimes we have the overutilization, especially if we use treatments with minimal benefits, not according to the evidence-based recommendations. So we have to keep in mind also this. In a study published in April 2022 in the Blood Cancer Journal about the financial toxicity, it's a systematic review, have seen that the hematological malignancy outcomes have remarkably improved, but in the other hand, the financial toxicity has increased. And it's particularly pronounced, those are the results of the study, pronounced among patients with hematological malignancies. And those patients often face unique symptoms and a quality of life challenge during their livelihood. Certain hematological malignancies, like, for example, acute leukemia, are disproportionately managed in patient settings, and most of them will have higher out-of-pocket costs. Sometimes we have patients like with the chronic myeloid leukemia, they go ambulatory patients, but they have this need of small molecule inhibitors that are very high in prices. And this understanding, this prevalence of financial toxicity would impact the outcomes of those patients. XIA1 had made in 2023 a review in the oncology hematology about the interventions for financial toxicity among cancer survivors. And this was a scoping review speaking about financial navigation, because we have to screen and face what are the unmet needs about the financial toxicity. We have to do a financial counseling. We have to make an education about the insurance and also the multi-psychological care, health financial assistances. And also we have to assess the intensive symptoms assessment. And so we have this four-step approach. Acknowledging and understanding the problem of financial toxicity is the first step. Second, we have to quantify this problem, and we have to engage the key stakeholders and fostering communication with them in order to implement, in the first step, implementing solution at various levels of healthcare system to resolve this financial toxicity in these patients. So, to measure the problem, we have various tools, but they are not uniform consensus about this. The only validated is comprehensive score for financial toxicity cost, and here is the score in the right side of your screen that it can be used. For example, I know that I have enough money in saving, retirement, or assets to cover the cost of my treatment, and the patient must respond, for example, not at all, a little bit, somewhat, quite a bit, or sorry, or very much. And after that, we have an accumulation of the points and evaluate the financial toxicity with this cost that is an adequate measure of financial toxicity with correlation with health-related quality of life. Another, it will be also in-charge financial distress, or a IFD-FW scale from 1 to 10. And this is really important to use the normative descriptive terminology for interpreting this course, as you see here in this image. So what is important is that the most effective way to reduce the individual's out-of-pocket costs is to ensure that the patient have adequate health insurance. And here you have the cost, the coverage, and the admin. What should we know about the health insurance terms and policies and practices that minimize cancer patients' out-of-pocket costs can improve survivors' health quality of life and also the psychological health. Another point we have to keep in mind, we have to engage stakeholders and fostering communication. And important is that we have to make sure all the information regarding our projects about the patients that should be presented in a transparent way. We have to communicate in the manner that works best for the stakeholders. And we have not to judge what are the stakeholders' values and to seek what are why and how. We can provide also good feedback, and we have mostly to keep a careful record of all the aspects of the stakeholder communication in order to implement the solution that could be through the international societies and guidelines to make better guidelines, to make better approach for the patients, better stratification and better prognosis, and also the treatment. We have to implement the solution in the national level in order to reduce the cost of cancer treatments for those patients. Also in the hospital level, we have to make sure the cost transparency, availability, the being able about the counselor, financial counselor in the hospital, and also we have to eliminate these low value practices that are not effective. And we have to implement solution in the level of also physicians and the patients. For example, there are charities that support the patients in need. In some countries, the government provides financial assistance, and those information should be available upon contacting the patient advocacy organizations. So in conclusion, financial toxicity is not a policy issue, but a real clinical problem with adverse consequences for the patient, also for their families. Objective measurement, recognition, and discussion, it's an important step to keep in mind. Also, the patient support groups have a big role by providing the appropriate support, information online, and to address this financial toxicity. And the cancer societies should take their responsibility for more seriously in eliminating low value practice and also to advocate for making available the last treatment, but insurance covered of those treatments for the patients. Those are my references, and thank you. What I really would like to ask, it's something to cure the high cost of medicine. Thank you very much for listening, and I am open for questions.
Obvious food accessibility and honey practice during SARS-CoV-2 pandemic in North Benin. The Republic of Benin is a West African country. This country is dependent on subsistence agriculture, cotton production, and regional trade as the basis of its food security as well as economic development. Its agricultural development is hindered by factors such as lack of modern farming technology, poor soil, high food price, and inadequate storage, preservation, and food processing. The country is also highly vulnerable to climate change, and recently COVID-19 pandemic contribute further to food insecurity and nutritional instability. In this country, the number of COVID-19 cases was of 597 at the date of the 17th of June 2020. A severe pandemic causing more than 25% reduction in labor availability could lead on great food shortage. The quick identification of the most critical of COVID-19 pandemic to the food system of Benin is necessary to implement sustainable mitigation measures. The aim of the study was to determine the dietary behavior, food accessibility, and handling practice during SARS-CoV-2 pandemic in Benin and the relationship between these components. Specifically, it was to describe the status of food security and nutrition in Benin before the COVID-19 pandemic, to evaluate the food accessibility of the household during SARS-CoV-2 pandemic in Benin, and to characterize the dietary behavior and the food handling practice in the home and restaurant during SARS-CoV-2 pandemic in Benin. Methodologically, the survey was carried out in the Department of Alibori, Atakora, Atlantic, Bogu, Kolin, Kufo, Donga, Littoral, Mono, Weme, Plateau, and Zoo in the Republic of Benin. This study area covered all the 12 departments of the Republic of Benin affected by the SARS-CoV-2 pandemic. About the analysis of food security and non-communicable disease occurrence in Benin before the pandemic of COVID-19. The analysis of food security and this non-communicable disease was made from the data collected and adapted from the database of our states on the food security indicator value of Benin in 2020 and from the review paper of Tuga and Tewis. About the characterization of dietary behavior, food accessibility, and handling practice. For this part of the study, data collection was carried out among households by using a survey guide. The survey guide gathered the following information: socio-demographic profile of the respondents, the government measure observed during the SARS-CoV-2 pandemic, the food access, the dietary change during the SARS-CoV-2 pandemic, the food handling change during the SARS-CoV-2 pandemic, the food quality management standard used, and adaptation mechanism. During the survey, the respondents were invited to remember themselves the different change in their food environment, food handling practice, and dietary behavior since the, the occurrence of the SARS-CoV-2 pandemic and the coping measures used. A sample of 124 households and 600 respondents were surveyed throughout the country. After interview, the answers were obtained from the survey guide were encoded and analyzed using the statistical analysis system. After examination of the database, the data were analyzed using R and SAT software. The procedure proof correct of SAS was used to do the factorial analysis, and for quantitative variable, an analysis of variance at single factor was used, and the type of food handling practice was the only source of variation. The mean were calculated and compared by the student test. The frequencies were calculated by PROFREC procedure of the statistical analysis system, and a confidence range were calculated for each frequency. About the results, it appeared that about food security, the non-communicable disease occurrence, the dietary change in household during the SARS-CoV-2 pandemic, it appears that the situation has been exacerbated by the new coronavirus pandemic. About food access during COVID-19, 80% of respondents found that their dietary needs has been challenged by the COVID-19 restriction measures. This challenge affects infants as well as children, pregnant women, breastfeeding women, elderly people, and people with a chronic disease. Overall, the price of the food products has increased on the local market, and this change in the price limit the ability of 80 households to acquire sufficient and safe food. The main non-communicable disease most reported during the study were diabetes, cardiovascular disease, mainly asthma, obesity, and some cancers. Similar impact of COVID-19 on food security and dietary behavior were also reported in the literature. In conclusion, the results of the current survey revealed that hunger and food security level from the year 2000 to 2018 in Benin remain unsatisfying. This situation has been exacerbated by the new coronavirus pandemic. About food access during the SARS-CoV-2 pandemic, 80 dietary needs have been challenged by the COVID-19 restriction measures. Benin government must develop a new strategy to improve food and nutrition security governance to mitigate the impact of any pandemic on food security. In perspective, the dietary determinant of non-communicable disease in Benin may be investigated and addressed. Thank you for your attention. Can you hear me?
Of Santa Maria. In different countries, it is called my way, partera, comadrona, or matrona. I am 20 years old, and on this occasion, I am going to explain to my article publication, Antifungal effects, Foeniculum Vulgare Mill essential all, a strain of Candida albicans in vitro. Introduction. The frequency of Candida albicans varies depending the geographic regions. In the United States, Europe, and Australia, Candida albicans is the most common species with percent between 76 and 89%. In some countries of Africa and Asia, the percent of Candida albicans is high. Pathogens that produce fungal infection, such as Candida albicans, are common and may impact the skin and mucosal surface causing system. Of all the species, Candida albicans is the most prevalent causes agent of mucosal and system infections, and is responsible for around 30% of fungal infection. Over the globe, it has been found as the primary cause of leaf treatment invasive infection for the last many decades. Despite therapy, the death rate is near to 50%, particularly under hospital circumstances. And the materials and methods is this was comparative prospect and experimental study carried out the microbiology laboratory of the Catholic University of Santa Maria and the National University of San Agustin. This was a comparative prospect and experiment study carried out of the microbiology laboratory of the Catholic University. No? And the pretty plates were prepared with soured agar, cultured medium, allowed to solidificate and suspected bacterium of Candida albicans. 115 of medium was prepared and pretty dish. Method has performed. A sterile test was performed. Foeniculum Vulgare set or was shown agar plate to see if the essence oil contaminated. 30 is one the finalized oil was obtained. It was placed in different petri dishes. The placement of native certificates Candida albicans finalized oil is clotrimazole for incubation. After 24 hours, the cultivation is the inhibitory halo was evaluated. We got two types of Candida albicans. The first, a Candida cytological sample for patients with Candida, which were called native Candida. The second was obtained from the gene laboratory of Peruvian, Lima, Peru. This was a certificate, ATCCC. In this article, the result is that the antifungal effect of different concentration of phenol was found in 25%, 50%, 75%, and 100% through the growth of the inhibitors found is the Candida albicans certificate ATCC strain where the inhibitory zone with 100 phenols essence oil was 50 million, and with clotrimazole it was 35 million. It is also evidence that antifungal activity increases as the concentration Foeniculum Vulgare Mill increase. In this table, funicular effect of different concentration of phenol was found in fourth concentration, 25%, 50%, 75%, 100%, through the growth of inhibition halo. In the native Candida albican strain, where the inhibitory halo is with 100%. And different with clotrimazole, it was it's also evident that the antifungal activity increases as a concentration of Foeniculum Vulgare Mill increase. When comparing the inhibition zone in the different concentration of the essential oil of clotrimazole, it was found that the large inhibition zone was obtained at the 100% concentration with a zone of 50 million in about the native strains, and the ATCCC, exceeding the diameter of the inhibition halo caused by clotrimazole with 38 and 35 million respectively. This effect caused by just of genus Candida have increased. In discussion, in this study, the antifungal activity of the essential oil of phenol was observed when a concentration of 100 was applied to ATCC strain of Candida albicans. My conclusion is in Foeniculum Vulgare it evaluates traditional medical or significant roles and the development and formulation of novel medication and potential clinic application. Numerous studies have shown that phenol compounds found and phenol exhibit powerful antioxidant properties. The results of these studies suggest that this beautiful form is maybe developed a new pharmacologic agent which may be without significantly to human health. Thank you very much for your attention.
Thank you. That was an excellent presentation. If anyone has any questions they'd like to ask.
You probably know bilinguality is the ability to speak two or more languages. And oftentimes when we do bilingual research, bilinguals are characterized based on how they learned those two languages. And so simultaneous bilinguals are individuals who pretty much have learned and used both languages from birth. And sometimes in the literature, they're referred to as crib bilinguals because of this. Sequential bilinguals, the individual begins with one language, but they learn their second language relatively early, typically in childhood. And then late bilinguals, the second language is learned much later, after early childhood. And here in the U.S. where we are, this is sort of the most typical for children who are raised in monolingual households. When we look around the world, we do see that bilingualism is more of the norm than the exception. And so worldwide, some estimates say that between 50 and 70% of the world's population is bilingual, and that about 66% of children are bilingual. If we look just at Europe, respondents to the 2006 European Commission survey showed about 56% of people in Europe are bilingual, and in Canada, about 35%. So when we look into the bilingual literature, we do see that there are some cognitive benefits potentially for being bilingual. And some of those benefits come in executive control, suggesting that bilinguals may have may do a better job sustaining attention, inhibiting irrelevant information, switching between tasks. There's some evidence that bilinguals may manage distraction better and have better attentional control. We can see that these advantages may result in some other things like better academic achievement. And something that has come out in the literature is that bilinguals may actually fare better in older adulthood. So that bilingualism may give bilinguals some type of cognitive reserve in older adulthood. So we do think that being bilingual does sort of shape our brain networks. It gives people the ability to communicate with multiple groups, and that bilinguals oftentimes have better job and travel opportunities. Some disadvantages that have been reported in the literature are smaller vocabularies in each of the languages, but typically those words that are not there are those that are very low frequency words within each language. Sometimes they are slower and less accurate in naming pictures, suggesting maybe some type of competition, and sometimes more effort is required for word retrieval. So today we're here to talk about code switching, which is the process of switching back and forth between two languages in a single conversation. And this involves phrases, clauses, and complete conversations. So this is not simply just borrowing a word from another language. And this is a strategy used by many bilinguals despite their background. So some reasons for code switching: it can facilitate communication. Sometimes when the person doesn't know a particular word or a phrase in a language, sometimes code switching is useful for paraphrasing, or oftentimes we know when we look at two languages, sometimes there's really not an exact translation equivalent in each language. So switching to the other language helps to provide meaning. Within a social context, people may code switch to exclude others, maybe that do not speak those languages or one of those languages. But oftentimes it's to include others that also speak both of those languages to build community. It can ease social tension, and sometimes bilinguals may code switch into another language if an idea that they're expressing is perhaps somewhat embarrassing in their first language. So to provide some emotional distance, or potentially a way to emphasize an important point. Some factors that influence code switching are language proficiency and culture. So code switching in the literature most studies find that code switching actually demonstrates high bilingual ability versus a deficit in one or the other language. People who report high levels of proficiency tend to have more positive attitudes about code switching, and people who have a more bilingual identity or bicultural identity is associated with more positive attitudes for code switching. When we look at how people code switch at the level of grammar, we do see that code switching is influenced by the rules of grammatical structure, and then the dominant language or the language that people may be speaking at the time, the matrix language, may provide the grammatical structure for code switching. So the main study that we'll be talking about today looks at code switching between German and English. And one of the challenges in code switching in these languages are the differences between German and English, particularly in grammar. So when we look at German, German has grammatical gender. They have 3 categories, which we don't mark in English. German also marks different cases, oftentimes with articles, which we don't in English. And so in English, typically cases marked by word order. And then the word order within some phrases, English, typically within phrases, it will be subject, verb, object, but German word order tends to be more flexible and in some cases also uses that subject, object, verb combination. And so a lack of congruence in grammar and proficiency may influence where these switches take place when they take place. So when we look at studies of German code switching, we see that many of the studies just look at natural conversations. They may take place within the context of case studies, naturalistic observations with children, or looking at frequency judgment in adult speakers. So how often or how likely might a code switch happen, and also code switch sentences that are generated by experimenters, where we look at things like reading time to see if a particular type of switch is more problematic than others. The current study that we'll talk about today examines whether code switching between German and English can be induced in a more experimental context.
Good morning. Dr. Sumutka, you can go ahead and keep sharing. So
sure.
Yeah, that would be easier.
Okay.
Good morning. My name is Lily Halstead. I'm a professor of cognitive psychology at Queen's University. I work with my colleague, Dr. Sumutka. So we came up with this experimental paradigm a number of years ago in 2015 to study whether or not it is possible to make code switching happen under the laboratory conditions. So bring on code switching among bilinguals. The method was first used for Spanish-English bilinguals. And these people, they had to be competent enough in Spanish to sit through a half-hour interview in Spanish, and they had to have, have some language history in Spanish. So the paradigm works like this: the participants who are bilingual are invited to the lab. They come in and they're introduced. And Dr. Sumutka, if you could share that picture, the next slide. They come in just like here. There is an interviewer, and then the participant sits and enters the room. The interviewer is in the Spanish initial language tells the participant that they are going to sit through an interview, and they are not to speak in English at any time. They should explain with the Spanish. And the kind of questions that the participant is asked is about the linguistic history, where, when they learn their first language, how often they use it, under what circumstances, so on. The interview usually takes up to 25 minutes. At a pre-designated time during the interview, an experimenter comes in. And the experimenter was chosen so that she did not speak any Spanish. So the experimenters are usually monolingual English speakers. She comes in, she approaches, and she talks to the interviewer in English. And then she remains in the room close to the participant and the interviewer. And the interviewer continues the interview in Spanish for the rest of the time. The question was whether or not after the interruption, the participants were more likely to code switch, so that knowing that someone who is in the room who doesn't speak Spanish and speaks English, are they more likely to break into Spanish or English, or are they going to remain with English? What we found was that the next slide is going to show. And also following the interview, they had to complete an 87 questionnaire on a laptop in the lab. The questionnaire is in English, and they were asked, you can see some of the questions about their history and background of their native language or their first mother language, and then English, and how often they use it, under what circumstances they use it, and so forth. So to prove the concept, what we found was that, the next slide, that the results show that, in fact, about 33% of the participants code switched following the entrance of that experimenter who only spoke English. And then the background of these people who were they're more likely to do it was members of the community, so slightly older participants, and also that their average age was about 38 years old. And then the people also whose mother was born in the United States. So we found the initial study that, yes, it was possible to produce code switching in the lab, and as a result of a person, an experimenter walking into the room who only speaks English. Following this, we thought, okay, is this going to be only something that with the Spanish, or is it going to be with other languages? So next slide shows that we did the same procedure, 4 languages: Spanish, French, German, and Arabic. Spanish, French, and German are Proto-Indo-European languages, some language similarities, although not apparent, and then Proto-Afro-Asiatic language, Arabic. For each group, we had 20 participants, and the interviewers who helped us with this study were native speakers of Spanish for a French group, French, a native speaker of German for the German group, and native speaker of Arabic for the Arabic group. A total of 80 participants. The results of this study, and the participants were this time tried to stay closer to the age group, although there were some community participants, and the mothers of, and this is the last column, shows that what percent of the mothers were born in the United States, and what percentage the English was, at what age, and all that were acquired. Next slide, and then we see for a Spanish bilinguals, 10% code switch. For French bilingual, 55%. For Arabic bilinguals, 20% code switch. But for German bilingual, no one code switched at any time. This was puzzling to us, and we thought, okay, maybe it has something to do with the age of learning the language, self-described fluency, comfort in speaking a target language, or frequency of embarrassment of speaking that language. But none of these factors seem to play an important part in this. None of it was significant. So the question was, why Germans do not code switch? So as a conclusion for that study, we found that all the different languages, Arabic, French, and Spanish, were likely to code switch. The percentage range from 10 to 55%, but the only language that did not code switch was German. After this, we thought, okay, maybe we needed the control group. So perhaps they would spontaneously code switch. So the next slide shows the Spanish code switching. We this time experimented with the Spanish again, simply because at Queen's University in North Carolina, there are more Spanish speakers to recruit as participants to native speakers. And we invited 52 fluent bilingual Spanish speakers. The whole procedure was the same, except for one difference. And this one was at the designated time, at the random, for the control group, no one would come in. The interview would continue. But for experimental group, the experimenter would interrupt the procedure just like the previous studies. So our aim was to see whether or not people in control group would code switch regardless of any kind of interruption. What we found was, and this is the participant characteristics are very similar. This time we were trying to be very, very careful with the participant, perhaps something about the linguistic history. So we chose only students, and you can see at the last column the percentage of the ones whose mother was born in the US, because it seems to play a factor, as I said earlier. The next slide shows that for the experimental group, 38% code switched following the post-interruption, and for the control group, only 4%. And so this was significant. And one more click, Doctor. Yes, and for the pre-interruption, for experimental was only 12%, and for control was 19%. Therefore, it seems to be that the interruption plays a role in code switching. So now that we know that it seems to be the case that interruption is, regardless of control or experimental, makes a difference in code switching, we decided to now do the final study in German to see whether or not we can induce code switching among German bilinguals with a control and experimental group. So this time, the same thing, and 23 fluent German speakers, and the interview was done all in German, although the interviewer for this particular study was not the same as the previous one. This was 8 years later. So it was, but again, another woman who was born in Germany and German speaker. What we found was among the participants were very similar, again, college age participants, and all, as you see, they acquired German as their first language, mostly students, and then the mothers, none of the mothers were born in the US, so they are all German speakers born in Germany. What we found was the participants still did not code switch, neither for experimental nor for control group. It seems to be that there is something about a German speaker bilinguals who, under laboratory condition that other languages code switch, German speakers do not code switch. And the question is why? There could be many possible explanation for this. Next slide would address that. One of them is lack of congruence between English and German. Maybe it's structurally the languages are so different that the bilingual speaker sticks to that language. And maybe the highly rule-governed nature of German grammar, going back to a little bit of linguistic determinism, that perhaps rule-governed languages also make people more likely to follow rules and instructions that are given initially. Or it may be cultural differences that makes them more likely to follow the instruction rather than trying to include someone who just entered the room and doesn't speak that language. That is up for speculation, but next. And our next steps are, and based on our conclusions, again, we found all languages, all four that we tested, code switch except for German. So we don't seem to be, maybe other experimenters would be able to, but we don't seem to be able to induce a code switching among Germans. And the most often significantly code switching is seen among Spanish speakers, that seem to be more readily willing to, based on two different studies, code switch, followed by French, and then finally Arabic. And there was, the question is either an interruption or no interruption. Germans seem to stay with German. Our next steps one is to follow up the Arabic and French studies with a control to see if we can again induce code switching in those populations and those bilinguals. And this time, a possibility of reversing the languages, so conducting a purely in English interview with bilingual Spanish speakers, asking not to code switch into Spanish and then interrupting with the Spanish experimenter to see if Spanish bilinguals speaking in English at some point when somebody who speaks Spanish walks into the room are more likely to code switch into Spanish. I'd be happy to answer any questions, and these are our references. Or either one of us be happy to answer any questions.
Thank you so much, doctors. That was a really excellent presentation. It's very insightful. And like both of you said, if anyone would like to ask any questions, you could either turn on your mic and directly ask, or you can drop it into the chat box.
And so this study here is not so much a study as it is a literature review, but a very comprehensive one where just looking at the history of this work over time. And my goal here is to help to inform those of you that might be interested in emergency medicine research about potential opportunities, current gaps in the research. So I'm a teaching professor at Wake Forest University, and I'm also a EMS consultant. I work with one of the largest agencies in our country, down in North Carolina. So just kind of quick, outline here. I'm just going to run through just a brief introduction to this research area, just so everyone kind of has a baseline understanding. And then we're going to go through deep dive of the literature, and I'm just going to kind of, spend not too much time on each paper, but just kind of give you the highlights of kind of the evolution of this work over time, and just kind of, what have the trends been and where it landed today. And we'll do a quick comparison of methods and then just a brief conclusion. So, we talk about EMS, emergency medical services. The goal of that kind of service is to provide out of hospital acute urgent medical care, and as well as transportation to clinical care facilities. And the calls that they respond to can range in severity from very high priority calls, things like cardiac arrests, or, major, potentially fatal injury, all the way down to non-emergent, we call non-emergent transports, where you may have someone who just needs to have a medically supported transportation from one location to the next, maybe just bringing them to, maybe a very elderly person, bringing them to their regular doctor's appointment. So again, the range of the service provided is very large. But in terms of forecasting and predicting, our goal really is to focus on those highest priority calls and minimizing our response time to responding to them. And we think about EMS agencies broadly around the world. Some are public, some are private, some are a combination of a public-private partnership. Like we have in our service area that I work with, it's a public-private partnership, but many of them are actually supported entirely by local municipalities and local governments. So the resources obviously vary based on their funding model. But if we look at EMS research very broadly, if all the possible really operations research that has been conducted, this is kind of a list of the categories of the type of problems that people have worked to solve. A lot of the work you'll find if you go to just Google Scholar and start looking around, you find a lot of work related to location problems. Where do we locate our ambulances for dispatch? When they're dispatched, how do we redeploy them over time? This has been a real intent focus of many researchers in operations research specifically. But there are other focuses as well, one of which is forecasting. And within forecasting, there's work that's been done for call demand forecasting, which is what I'm talking about today, but also forecasting projections for workloads and travel times as well. But when we would just define this problem very quickly here, when we talk about EMS demand forecasting specifically, we're looking at predicting call volumes for future periods. And so those can be done at different granularities. And this is a very important distinction that when you're looking at these studies, you have to be carefully, keeping this in the back of your mind is what is the granularity at which someone is doing these forecasts? Because that really makes a massive difference. Are they forecasting annual? Are they forecasting monthly, weekly, daily, or hourly? And are they doing those forecasts at a granularity of space that is operationally viable? And what we mean by operationally viable is it useful to us to know how many calls we're going to get in a particular area. And, the bottom line up front is basically you can get too granular to be useful, and you can also be too broad to be useful. And so I'm going to kind of frame this as strategic, tactical, and operational planning when we get into the comparison of methods. But basically, we predict how many calls we're going to get in a future period of time. We staff our workforce based on those predictions. And that includes our ambulances equipped with a combination of paramedics and or EMTs, depending on really what we have available to us and what we think our needs are going to be. And then we deploy those ambulances throughout what we call the surface area, which is a geographic region that we're responsible for responding to calls in. And then we adjust, as the day goes by, as calls come in, we adjust where those ambulances have been deployed, and that's referred to as redeployments. But what's interesting, if you look at all the different studies that have been done, going back to list here, everything here, I can make the argument that everything here depends on call demand forecasts. That is the input to determining how you dispatch and route, how you deploy, how you redeploy, what your workforce is. It's all based on these forecasts, which underlines the importance of this particular arena of work. So a bit of a history lesson. I hope you're interested in history here, but going back to when did this all start? The first recorded study was a management science approach in 1971, where William Hall basically was the first to go out there and collect EMS call data in an attempt to just identify trends. And this forecast really, or this study really wasn't a forecasting study. It really was more of a demand analysis study, just to try to understand, what contributes to demand, and how that can inform policies that agencies adopt. But he was the first to really kind of put his finger on this as an interesting issue to look into. Shortly thereafter, also in 1971, Aldrich here picked up the ball and developed a regression model using call volume data and incorporated some census data that spanned over a 1-year period. And their study focused on Los Angeles in particular, and they were looking at socioeconomic data to really try to figure out, what are, demographic or socioeconomic variables that influence demand. Who's more likely to call for ambulance, services versus someone who may not be. They also looked at some land use variables and they were just trying to kind of put everything out on the table to see what might be useful to forecasting annual call volume at an aggregate level. And so that's when I talk about granularity. This is very big picture, just looking at an annual basis. Throughout the 70s, there's a couple more studies, again, all of which focused on regression, where they're just incorporating different variables using call and census data. And so here's just a quick summary of those studies. Basically, what they found was things that might seem very intuitive to us today, that demand is higher in areas with higher densities of children, elderly people, unmarried, whites, non-whites, and low-income families, is where they found demand to be, again, more concentrated. And that increased demand correlates with the fewer occupants per household. So, thinking about singles, possibly seeking out medical care through ambulance services. And access to healthcare was a big factor where they expect demand to be highest in areas with a concentration of people of lower socioeconomic status, regardless of the presence of real emergencies. And this is a trend that has continued. This is nothing novel. It's been around for a long time. This idea that people that don't have access to routine primary care will inevitably seek out care through the emergency medical service system, regardless of their ability to pay. And obviously that speaks to a broader social issue that's outside the scope of this discussion. But that is a factor that has continued over time. Researchers did not include other exogenous variables that might intuitively be of interest to us, things like weather and traffic. But we'll see in some future studies, there are some researchers that incorporated weather as a possible, predictive variable to demand. In 1998, McConnell and Wilson picked it back up. There was a big delay there in some research, but they were the first to really focus in on different age groups to try to figure out basically what are the categories of demand on an age level. They also looked at gender and ethnicity. And nothing really earth-shattering here. Their results were consistent with earlier investigations, but they were, again, really focusing on, in terms of EMS incidents on a populace, who is more likely to call for these services based on age, and they broke those into traumatic medical incidents, or just generic medical incidents. And again, the results are not entirely surprising. We find that as people age, they're more likely to have medical incidents or trauma incidents that require EMS response. In 2007, Shinoff and group were the first to really do what was this was a seminal study. Everyone references this study because they were the first to do some time series forecasting, where they were not just looking at regression, but also using ARIMA with time as the central variable and no socioeconomic variables or spatially distributed forecasts. So this is where there was a shift from focusing on annual demand at an aggregate level to focusing down to daily and hourly level, and to really produce some operationally useful forecasts. So not analyzing the populace so much as trying to figure out how much demand we're going to need or how much demand we're likely to incur at a certain unit of time that's useful for deploying our ambulances and responding. And they were the first to really, raise the flag that, again, it's pretty intuitive when you think about it, but that EMS demand varies significantly based on the time of the day and the day of the week. And so like these graphs are very interesting to look at least I think so, to see that, there's, and you can take really any EMS call volume demand. I've done this with tons of different data from around the world. And you end up with these patterns where, depending on population growth, you'll have this subtle increasing trend over time. Obviously, if the population is declining, you'll have a sudden decline over time in your call volume. They're directly correlated to one another, but you also have seasonal and cyclical patterns that emerge over month by month. Thinking about just we've heard like the fun spurious correlations. I'm sure you've heard different spurious correlations, like thinking about You know, when ice cream sales increase in the summer, so does the murder rate. All right, these spurious correlations, but the reality is that the correlation is that the hotter it is outside, the more human activity there is, then the more crime there is. And the same applies to EMS, right? That in the warmer months, when there's more activity going on, people are out and about doing things, you're inevitably going to have more medical and traumatic incidents that require EMS response. But where it really gets interesting is when you average out call demand on a weekly basis, you get these really nice, smooth, curved lines, right? That this very repetitive seasonal pattern based on the time of the day. And what we can take away from this, and again, I've plotted this out for different service areas, and they all come out very, very similar. It's all based on human behavior and activity. The more active you are, the more likely that there's going to be demand for emergency services. But what we can see here is that the demand for EMS is relatively stationary based on the time of the day and the day of the week. And so for that reason, time series forecasting and even simple time series forecasting, like using moving averages, is actually a very effective method. And again, another little bottom line up front here, that's actually how we still do it in industry. Believe it or not, with all the advancements with things like forecasting methods and machine learning that we're going to talk about later, we still do most of our forecasting using moving averages, variations of moving averages, because they're just so darn effective. They're very, very effective for long-term forecasts, and they're pretty effective for even hourly forecasts. But where the rubber hits the road is when we get down to spatial granularities. So another body of work that was really important to mention is in 2007, Brown and group, basically they did a effectiveness study looking at a very popular industry practice called system status management, which anyone that works in the EMS is very familiar with this. It's been around for a very, very long time. And variations of this methodology are actively practiced by EMS agencies around the country in the United States as well as in Europe. And so they were the first to really study this practice. And they found that it overall performed pretty well. There are a couple, and I have reference to this later I can share, but there are a couple basically time series type forecasting methods to calculate average peak demand, smooth average peak demand, and 90th percentile of rake demand were the methods that are part of system status management. And they have decent prediction accuracy over time when you think about it in a kind of overestimation versus underestimation of demand. That's kind of something that we really focus in our industry. Is we're not so concerned about overestimating demand. We're much more concerned with underestimation of demand, because again, we'd rather be in a situation where we have a truck available to respond to a call and not need it than need a truck and not have it, right? So that's another kind of lens to color all these forecast methods under. All right, so then in 2019, this was the first study that came out of my research group before I actually joined the team. And this was studying Mecklenburg County. And this was the first study to attempt to produce EMS call volume forecasts, not just based on time, so what we call temporal forecasts, but spatial temporal forecasts. So looking at different spatial granularities. And so how did they accomplish this? What was their approach? Essentially what they did was they divided the service area. So this is Mecklenburg County, North Carolina. They divided the service area into equal grids, 2x2 and 4x4 mile grids. And they used those different grids as basically features in a machine learning model. And they trained it based on historic call demand and tried to predict what demand would be within each one of those square mile grids. Now, while this was a very kind of simple and somewhat naive approach, it did prove to be somewhat effective. But the problem they ran into was the level of granularity. Basically, what happens is when you go down to a really fine level of granularity using maybe an approach like this, what you end up with is called a zero inflated distribution, where if we think about a particular hour of a day, so this graph or this graphic here on the right is showing you a 4x4 square mile grid solution. And if you look at most of those grids, they're 0. And so this is for a single hour of the day, basically. Actually, this is a 3-hour period, sorry. But this is 3-hour period of the day where basically most of the locations throughout the county, you're going to have 0 calls, and others you're going to have several calls. And the problem with this is that if you're trying to compare the performance of even a simple method like time series or a more advanced method like a machine learning neural network, f of x equals 0 will beat it every time in terms of performance. Basically saying that if I'm looking at just accuracy at the aggregate level, if I just say, well, the forecast is likely to be 0, I'm going to be more accurate than any method in existence because there's so many zeros, or it's a 0 inflated distribution. So this was the core weakness of their approach, was they essentially went too granular. So very good in theory, but not so good in application. Continuing into 2012, there was some researchers that explored another popular time series analysis approach called singular spectrum analysis. And they applied this method to some Welsh ambulance service data and compared it against ARIMA and Holtz-Winters, which are 2 very popular time series forecasting methods. And they found that single spectrum analysis outperformed them for longer term forecasts. So these are 21 to 24 days, but didn't do so well for really the shorter term forecast by comparison. And so this was a possible alternative to time series methods, but they did not do it at a more detailed spatial level. Wong and Lai in 2014 were the first to incorporate weather into forecasts. And basically what they found was that, not surprising really, that weather is not entirely, or demand is not entirely dependent on weather. We know that, but they found that it only marginally improved forecasts in some cases. And weather is going to be an important factor for very limited time scopes. So we could think about hurricane season in the southeast of the U.S., right? That obviously can be a big, determinant factor of who needs medical support. Snowstorms in the northeast of the U.S., right? That's another thing. But it's one of those things where including weather in your forecast, all the time, isn't necessarily going to make that big of a difference. But there has been very little work done in this, really just this study, and I think there's maybe one other. So there is more work that could be done in looking at the weather's factor on short-term forecasts. And then we get into some other methods in 2014. This was a study that did attempt to do some spatiotemporal forecasts using what's called a Gaussian mixture method, which is a probabilistic method that is basically looking at demand densities. And so they looked at data in Toronto and found that their approach could actually better estimate demand than some previous approaches. But again, nothing earth-shattering here. They did do spatiotemporal forecasts. And so I think the highlight here is that there was a shift in trend after Setzler's 2009 paper. There was a shift in basically saying we shouldn't just be doing temporal forecasts. It's not operationally useful to us. We really need to be diving into the spatiotemporal forecast where the complexity is higher and the value is higher. And so that's what continues here. Chen, this group of researchers out of Taiwan, picked up the ball from Setzler and attempted to recreate their study using Taiwanese data and using a very similar approach with the grids. And not really shocking, they kind of ran into the same problem with the 0 inflated distributions, because again, they used equal sized grids to forecast at 3-hour level granularity. And it was, again, somewhat helpful, but not earth-shattering, didn't really move the needle a lot. In 2019, there was a unique study done that identified that this 0 inflated problem is real. And so you have to account for that when you're doing your forecast. And so they explored using a 0 inflated Poisson regression to forecast hourly demand across different spatial grid zones in Swedish counties. So they broke it up based on at the county, and I think they also did census tract level, but they didn't, or what the equivalent of census tract levels would be there. There's different regions in the counties. And they found that zero inflated Poisson was effective at handling data sets that have a higher percentage of zero call entries. So this was a promising approach to say, hey, like you need to account for this high concentration of zero call volumes that you're going to inevitably occur or encounter rather when you get down to this level of granularity. And then bringing to more recent years here, 2020, Bandara, they introduced basically a custom approach to a long short-term memory neural network, basically a recurrent neural network, to calculate monthly EMS call volumes. And so, with this study, my chief criticism would be they didn't go deep enough. Monthly call volumes. I mean, I can tell you right now that a simple moving average can get close to the performance, if not beat the performance of an advanced neural network for monthly forecasts. This is not at a granularity that's very challenging to forecast. And again, I'm saying this based on what we do in industry. It's just not very hard to forecast it. But it's nice to see people are incorporating more neural networks and machine learning models and comparing them, benchmarking them against other models and time series. But this model they used to help with basically policy making and what if scenario evaluations for EMS demand planning. So they weren't really focused on operational. I'll give them credit there. They weren't really focused on the operational need, more at a policy level, which monthly granularity would be appropriate for that. And then almost through the studies here. So Lin, they're the first to explore using what's called a light gradient boost model, which is a gradient boosting framework that was developed by Microsoft. So again, looking at more progressive machine learning approaches. So they did a study in Singapore using a lot of data over a 10-year period. They included spatial, temporal, and demographic features. Features is what we call variables in machine learning, as well as short-term and long-term forecast there. Long and short-term historical demand as a feature. And, they found that overall they got pretty decent accuracy incorporating those factors, also incorporating some weather data. And so again, this is where they found that, hey, maybe incorporating some weather data is helpful. We just need to look at this a little bit further. And then in 2021, my research group, we put out a paper that focused exclusively on spatiotemporal machine learning, spatiotemporal forecasting using machine learning. And so what we did was we compared various machine learning methods, primarily artificial neural networks. We also looked at support vector machines, gradient boosting, and some others that didn't get included in the paper because the performance wasn't that great. But we compared the performance of that neural network against traditional forecasting techniques, moving averages, ARIMA, and specifically focused on industry. What is industry doing? Because the goal here was we want to benchmark the performance of machine learning models like a neural network against what industry is doing to see if we can actually beat it, right? Can we do better than what industry is doing right now? So we used 8 years of data for Mecklenburg County. And one, to pat myself on the back, one novel approach that we did was we basically said, listen, we can't encounter this zero inflated distribution problem. We need to avoid that. We need to be producing forecasts at a level of granularity that are operationally viable. So we decided to use a clustering approach before doing forecasting. So we used k-means clustering based on the latitude and longitude coordinates of all the calls in our data set. And we use that to create these dynamically sized clusters based on that demand density. And then we used the label of these clusters. So clusters, 0 through 6 or 7 or 9 or 8, we used different cluster combinations. And there was reasonings behind why we got to these clustering, both from industry and supported by statistics. But we use that feature and then trained the model on each individual cluster. And so we avoided the zero inflated distribution problem entirely because we went to a level of granularity where that's just not going to be present. But we also back-checked that with our industry partners to say, is this a level of granularity that is operationally useful, which was an important component to it. We also did see in our data that nice curved trend, that day of the week trend that occurs. And again, you can see that demand is relatively stationary for a given time of day and day of week, which is an important component. And so we not only train the model based on the cluster, we also train the model based on the time of the day and the day of the week, to really drill down to the particular scope that we needed. And we concluded that what we found was that using advanced methods like neural networks, it did give you a little bit of an edge for daily calls, not a dramatic edge for daily calls. And it did give you a decent edge, improved accuracy for hourly calls. But where it just completely crushed it was at the spatial level. It's not even close. The performance of neural networks and machine learning models, when you get down to spatial granularity, way outperforms way outperforms time series methods, moving averages, anything like that. And so that's, again, because of that added complexity of producing that forecast that was important. And then coming up to the last study here that we have included in this discussion, this group used what they call a meta learner algorithm, but it was essentially an ensemble of different algorithms to predict hourly EMS rates in New York City using a data set that also included weather factors. So they explored more machine learning models, generalized linear models, XGBoost, using a particular package. And they basically were able to produce forecasts at that hourly level, but they did not do it spatially, which was, again, kind of the trend of these studies. So just kind of summarizing a comparison, I know this is a big table, but just kind of looking over the trends, if you want to focus, like, for example, on this dimension here, you can see that, post 2009, most of the studies being done are spatial temporal, which, again, that's where the need is in the industry. We need better spatial temporal forecasts. We don't need better temporal forecasts. We can do that very easily because the stationary nature with even just moving averages is very, very good. And we can see that, obviously, with the hotness of AI, especially today, right? Machine learning models are what most people are digging into, which shows the most promise. And people still are shifting between doing what I would consider studies that are focused on strategic and tactical, which, like monthly, weekly forecasts, to more operational daily, hourly forecasts. There are a couple more papers that have been published over the past 2 years that we're still kind of digging into and looking over, that I didn't get a chance to include in this paper. But again, nothing really earth-shattering has happened in the space. So my takeaways here for everyone that might be interested in this work or diving into it themselves, feel free to reach out to me for references or conversations. But the prevailing trend in industry is still to use time series forecasting. I can tell you for a fact that's how we're doing it right now. It's tried, it's true, but it does fall short when we get into those finer granularities, which there is a need for a practical solution that's a little more advanced. And overall complexity and the underlying assumptions of these different neural network and machine learning models does impede widespread industry adoption. So the solution that's needed is practical and elegant solutions. Suggestions for future research is to exclusively focus on spatial temporal forecasting going forward. There's really just not a lot of value in the temporal forecasting methods in advancing the state of the art. I think it'd be helpful to revisit. So maybe go back to the themes of the 70s with that census data or socioeconomic demographic data, land use variables. Those things could potentially be very helpful. And all this is relative to the service area that we're looking at. Service areas, again, it depends on the landscape. It depends on the population density. There's so many variables that make these problems fun to study, because doing a study in one region of the US or another country in the world can be dramatically different from another. Thinking about doing a study in a rural or suburban area versus something like New York City, very, very different challenges to contend with in terms of moving people around quickly. And so I think it's also useful to incorporate variables of weather. No one's incorporated traffic variables. That's going to get into real-time dispatching models that could use those kinds of things. But anyways, so I hope that, while this was a lot of information, I hope that you found this useful, and happy to answer any questions that anyone might have.
Thank you so much. Does anyone have any questions they would like to ask?